similar webinars with national and international faculty, which included issues like non-alcoholic fatty liver disease, refractory ulcerative colitis, and management of obesity. Today, we are lucky to have excellent faculty as moderators and speakers and chairpersons who are going to discuss the common problem of swallowing, how we try to establish the cause of swallowing with esophageal motility measuring machines. We have the national and international experts who are going to deliberate about these issues. And with that, I'll hand it over to Dr. Ashish to introduce the topic and then carry it forward.
Thank you, Dr. Arora. Good evening, ladies and gentlemen. I bring you greetings from Sir Gangaram Hospital. And on behalf of Delhi Liver Foundation, I welcome you to this webinar on pathophysiology, diagnosis, and clinical evaluation of swallowing disorders. As gastroenterologists, we often get patients who complain of a variety of symptoms related to swallowing. As such, these symptoms are dysphagia, odynophagia, regurgitation, coughing during swallowing, choking sensation, and even nasal regurgitation. To understand the cause of these symptoms, we need to be aware of the normal swallowing mechanisms and normal anatomy and physiology of swallowing. And we also need to have a deep understanding of the pathophysiology involved in swallowing disorders. So in this webinar, we will understand from stalwarts in esophageal motility about normal and abnormal physiology and pathophysiology of swallowing disorders. But prior to this academic feast of the lectures and discussion on the swallowing mechanism and the swallowing disorders, the Delhi Liver Foundation would like to felicitate one of the greatest gastroenterologists in India. As you all know, that from last 3 years, the Delhi Liver Foundation, in the memory of Dr. S.K. Sama, has been recognizing and felicitating senior gastroenterologists who have made significant contributions in GI and liver field in India and who have dedicated their life in improving the GI and liver health of Indians. Today, the gastroenterological expertise in India is one of the best in the world, be it any field of GI specialty like hepatology, luminal gastroenterology, pancreaticobiliary science specialty, or therapeutic endoscopy. Indian gastroenterologists have made remarkable contributions all over the world. They have produced path-breaking research and remarkable innovations in endoscopic techniques and many more fields of gastroenterology. So today we would like to honor Professor Ramesh Rai, who is one of the pioneers in gastroenterology and hepatology in India and one of the greatest gastroenterologists Rajasthan has produced, and now we are very proud to have him here. And now I would like to hand over the proceedings to Dr. Piyush Ranjan, who will first tell us about Dr. S.K. Sama, and then Dr. Deepak Gunjan will read a citation about Dr. Ramesh Rai. So Dr. Piyush.
Good evening, everybody. Are my slides visible now?
Yes, yes.
So all the gastroenterologists must be aware of the contributions of Dr. Surinder Sama.
Make them full screen, Dr. Piyush.
We had good fortune of working with him and being mentored under his tutelage. Dr. Sama was born on 31st May 1934 in Firozpur, Punjab, and he did his schooling from Himachal Pradesh. He did his MBBS from Amritsar Medical College and subsequently his MD Medicine from All India Institute of Medical Sciences. He also did his WHO fellowship training in gastroenterology from Tufts University, Boston in 1970. He started his career by joining his alma mater in AIIMS, and he worked in AIIMS till 1974, during which time he established the Department of Gastroenterology at the institute as well as the GB Pant Hospital. In 1976, he joined Sir Gangaram Hospital as the honorary physician and gastroenterologist and served the hospital till his last breath for the next 36 years, including the chairmanship of this hospital from 1995 to 2006. While continuing his association with Sir Gangaram Hospital, he also founded his multi-speciality hospital, Sama Hospital, which is still serving the society in Delhi. He was the personal physician to the President of India. He was appointed in 2001. He founded the gastroenterology department in Sir Ganga Ram Hospital, now which has grown to become a center of excellence. He held various posts in Sir Ganga Ram Hospital, including the founder member of the board of management, which is a unique this thing in Ganga Ram Hospital, and subsequently he was elevated to the board of trustees. He was the chairman of board of management from 1995 till he stepped down in 2006. He continued to work actively for the betterment of hospital and the department even after that till his last breath. He was a teacher par excellence. He was a devoted academician, and he was a role model for many young medical students and budding gastroenterologists. His research career was very distinguished. He published nearly 51 high-impact papers in various national and international journals. In 1962, he first reported non-cirrhotic portal fibrosis, and subsequently this was built upon by various studies from AIIMS. He is also credited with significant research on hepatitis B, and he had great inquisitiveness and zeal to learn the latest technique in gastroenterology. He was a former president and a life member of Indian Society of Gastroenterology, and he organized multiple therapeutic endoscopic workshops in Gangaram Hospital. He was a life member of INSL, Indian Society Gastrointestinal Endoscopy, American Society Gastroenterology Association, and Association of Physicians of India. He was also a president of New Delhi chapter of Indian Medical Association. He was in the board of advisors of American Hospital Management Company. He had various awards to his name. He was awarded Padma Shri in 2004 for his pioneering research in liver diseases, including NCPF and hepatitis B. In the same year, he also received the highest Indian medical honor, the Dr. B.C. Roy Award, and he was a recipient of numerous other awards like Punjab Ratan Award, DMA Ratan Award, Bharat Jyoti Award, Bhaskar Award, Human Care Award, and Delhi Ratan Award. He delivered several award lectures such as the Presidential Oration in 1986, Dr. B.L. Kapoor Memorial Oration, Dr. K.L. Vig Memorial Oration, and Dr. R.S. Tiwari Memorial Oration. Dr. Sama, so here is remembering Dr. Sama. These few slides cannot sum up his entire journey of life, but for the young gastroenterologists, this is a reminder that there was a person who pioneered gastroenterology in India. It would not be an exaggeration to call him a father of gastroenterology. He was a teacher of teachers, astute physician, and he was a very, very able head administrator from the entire department of gastroenterology at Sir Ganga Ram Hospital. I pay my heartfelt tributes to Dr. Sama, and with this, I hand over to Ashish to further continue the felicitation of Dr. Ramesh Ruprai, sir.
Thank you, Dr. Piyush. Now, I would like Dr. Deepak Gunjan to read a citation about Dr. Ramesh Ruprai.
Thank you, Dr. Ashish, and good evening, everyone. It is my privilege and honor to talk about Professor Rai, Dr. Ramesh Ruprai, a former professor and head Department of Gastroenterology, SMS Jaipur, and he completed his DM in gastroenterology from the prestigious All India Institute of Medical Sciences, New Delhi. Being the first gastroenterology in Rajasthan, he has been instrumental in developing the super specialty department in Rajasthan. The initiation and establishment of Department of Gastroenterology in SMS Jaipur is the result of his untiring efforts. In 1998, he's also started DM program in gastroenterology under his able guidance, and he is very passionate and astute teacher. He has the credit of organizing 3 national N1 conferences of ISG, INASL, and SGEI successfully in Jaipur. He is a very keen researcher and has published more than 130 scientific papers in leading peer-reviewed international and national journals, and has authored several chapters in textbook of gastroenterology. In honor of his scientific contribution, he was included in the editorial board of World Journal of Gastroenterology from 2004 to 2009. He served as president of Indian Society of Gastroenterology for the year of 2007 to 2008. And also he was nominated as a member of Academic Council and is presently the chairman of Ethics Committee of Rajasthan University of Medical Health Sciences. He has also been nominated as advisory member of National Board of Examination for Super Specialty Board of Gastroenterology. At present, He is the Director and Professor Emeritus of the Department of Gastroenterology and Hepatology, National Institute of Medical Sciences, Jaipur. Dr. Ashish, over to you.
Thank you, Dr. Deepak. Now I would ask Dr. Anil Arora to virtually hand over the SK Sama Memorial Award to Dr. Ramesh Rupra.
Thank you, Ashish. I think it is my proud privilege to honor a legendary in gastroenterology who has been the pioneer and the pillar of strength of development of gastroenterology in whole of Rajasthan, not only Rajasthan, but whole of India. I had the privilege of working under him as a registrar when he had joined to do his DM in gastroenterology at All India Institute of Medical Sciences. We did have golden time with him, and under his stewardship and leadership, we learned a lot of clinical gastroenterology from him. I am proud that we have selected a very eminent person who truly deserves, with all the dividends, this coveted award of Dr. Sama, who has been primarily focusing on taking the field of gastroenterology and hepatology down to the root cause areas where the typical academic institution may not be able to have their own wings. With that, I think Dr. Rai would have by now, because this is the e-meeting, we cannot, physically hand over him the medal and the coveted shawl. I'm sure you would have received it. May I request Dr. Rai to please say a few words to us and to the gathering we have now. Dr. Rai, please.
So you're muted. Please unmute yourself.
Thank you, Dr. Anil Arora, for giving this opportunity to me to humbly accept the prestigious Dr. SK Sama Memorial Award. I feel great honor because I, though did not have a direct teaching under Dr. SK Sama, but I had great opportunities to be with him many times while he was coming to Jaipur and attending various conferences, giving lectures. And whenever I went to Delhi and Gangaram Hospital, he was so loving personality. He loved all his students and all his colleagues to greatest extent. And I feel honor and privilege that this honor has been bestowed onto me. I would just say Dr. Sama, such a astute teacher that he did not only influenced all those who came in his fold, and he developed such a great department of gastroenterology at Sir Gangaram Hospital, which is now being ably taken to the greatest heights by Dr. Anil Arora and his team. I would just say that Rajasthan was quite backward in the sense that most of our people did not know about gastroenterology, and it took me almost about 4 to 5 years continuing to go to door. That means from various centers in the city as well as in the districts, and try to make people convinced that gastroenterology is a specialty where we can deliver various types of services to all the ailing people. And I was fortunate to have a very astute team who did all the favors to me, and we could establish Department of Gastroenterology in 1989. And since then, we were fortunate that the whole national faculty, national teachers were so close to us that they visited us, and when we organized all the CMEs or the national conferences, we were blessed by all the greatest people in the gastroenterology. And gradually, my team started building up, and we could all do a joint work along with Dr. Nepalia, Dr. Sandeep Nijavan, Dr. S.S. Sharma, and all in developing our department. And now it has reached to a level in which we can say that now people are taking up their DM courses in the SMS Medical College as a second or first priority. And I feel honored that this department was started along with my colleagues, and we are now serving most of the people in the state of Rajasthan and Haryana, Madhya Pradesh, and Gujarat also. So I feel honored to receive this whole thing. My journey has been very arduous because uh, government sector to develop a department to get all those equipments which are necessary for the delivering the various therapeutic options to our ailing patients. It was great difficulty, but because of my uh, uh, efforts which we took along with others, the government gave us all the facilities and we could develop the department. We were the first to start the molecular biology lab in our department, and I was fortunate to have too many of these PhD students who did a lot of work, and we produced the dynamics of hepatitis E virus spread, and how it changes in the body, and how the secretion is taking place, and how the RNA is working in the body. So we, as a small effort, we could contribute to the gastroenterology in our state of Rajasthan. And I'm fortunate that all my colleagues have contributed along with me in development of the department. I again thank Dr. ANIL ARORA, the Delhi Liver Foundation for honoring me on this occasion. And I'm really feeling very proud, privileged to receive Dr. S.K. Sama Award. Thank you very much.
Thank you, Dr. Rai, and we are very honored to get it's a very we are fortunate to have honor you with the Dr. S.K. Sama Memorial Award, and we are thankful to you for receiving this award. So now we'll hand over the proceedings for the swallowing disorders, and for this I would like to invite the moderators, Dr. Rajesh Sainani and Dr. Monish Chabra. Dr. Rajesh Sainani is a consultant gastroenterologist in Mumbai, attached to Jaslok Hospital and Reliance Foundation Hospital. And he's a very senior gastroenterologist in Mumbai, and he has also received his fellowship from Royal Melbourne Hospital in Australia, and has attended large number of workshops and courses in the field of gastroenterology. Dr. Monish Chabra is director at the Department of Gastroenterology, Fortis Hospital, Mohali, and he has been associated with Fortis Hospital since 2001. He is a graduate from PGIMS Rohtak, and also did his DM from PGI Chandigarh. And he is the first person in North India to start narrow band imaging and magnification endoscopy. So we have these two prominent moderators to moderate the session on swallowing disorders. And we also have chairpersons, Dr. Piyush Ranjan and Dr. Deepak Gunjan. Dr. Piyush Ranjan is a senior consultant and professor of gastroenterology at Gangaram Hospital. And Dr. Deepak Gunjan is also assistant professor at the All India Institute of Medical Sciences. So I'm Dr. Rajesh Sainani and Dr. Monish Chabra. Please, you take over the proceedings from here.
Hi, good evening, friends. Welcome to this evening of good clinical discussion. Our first speaker today is Professor Shobna Bhatia, who's been my teacher, and she was professor and head of KEM Hospital, Mumbai, and currently is a professor of gastroenterology at the HN Reliance Hospital in Mumbai. Do we have Madam online?
Yes.
Yes, Madam.
Yeah. Okay.
Madam will be speaking on the normal physiology of swallowing. You can go ahead and share your slides and the screen.
Can you all see my slides, Rajesh?
Yes, we can, Madam. Can you make it full screen? Yes, it's full
Yes,
screen.
I've done that.
Excellent.
So my job today is to discuss normal swallowing. Just remember that swallowing helps us to keep up with our nutrition as well as enjoy the food that we eat. In our standard textbooks, swallowing was divided into 3 phases: the oral phase, the pharyngeal phase, and the esophageal phase. Today, I will be speaking about the pharyngeal phase a little bit, but concentrate on the esophageal phase because that's where the discussion about classification and pathophysiology is coming up. So starting with the anatomy of the esophagus, we know that the esophagus is composed of 3 parts: the upper esophageal sphincter, the esophageal body, and the lower esophageal sphincter. Now, what sounds very simple, that the upper esophageal sphincter and the lower esophageal sphincter, they straddle the esophageal body and open at the time of swallowing and close as soon as the bolus is transported into the esophagus. But the actual mechanisms that have been elicited in recent years show that this whole process of bolus transport is indeed a slightly complicated process and is stiffly regulated by the muscle as well as the neural compositions of the esophagus. So in short, if you look at the neurology of the esophagus, you have the upper esophagus, which is a striated muscle and receives its motor efferents from the vagus. But there is, of course, a sensory input as well. But the smooth muscle has more motor than sensory inputs. There is, of course, the mesenteric plexus, which regulates swallowing as well and is responsible for the beginning of secondary peristalsis, which comes up whenever there is a bolus inside the esophagus and has not come from swallowing. Now, coming to the upper esophageal sphincter, this looks like a very, very complicated diagram. This is the process of swallowing in the upper esophageal sphincter. And this whole slide, can you see the mouse from here to here? Rajesh, can you see the mouse?
Yes, we can see the mouse.
Okay. This whole screen that you see from one end to the other is less than 1 second, which means that the bolus traverses the upper esophageal sphincter in less than 1 second. And the events that occur are so coordinated that the food pathway is converted from the respiratory pathway, which means that in normal situations, we are using part of the same pathway for breathing. As soon as we start swallowing, the glossopalatal junction opens, the laryngeal vestibule is closed, and it's only then and then that the upper esophageal sphincter opens. And this is the upper sphincter opening. This is the normal upper esophageal sphincter pressure. This is the opening of the sphincter. And just before that, you see that the velopharynx has already closed. Now, this prevents aspiration. As soon as the bolus has crossed the upper esophageal sphincter, the muscle goes back into its original position and then breathing resumes. So the main purpose of this upper esophageal sphincter is to prevent aspiration and allow swallowing into the esophagus. So it's the same thing here, a little bit more detail. What you see is when you start swallowing, this is the hyoid and this is the mandible. The hyoid and the upper esophageal sphincter actually move up. Now, without the upper esophageal sphincter moving up, the larynx will not close, neither will the upper esophageal sphincter open. So at this point, the sphincter is closed, it's contracted. Again, here it is closed. But when it starts relaxing, that is, the food reaches the back of the throat and it starts getting pushed down the upper esophageal sphincter. Initially, the sphincter is only relaxed and is not yet open. So when it starts opening, that is here, it starts opening here and it is still relaxed here. And then after about less than 300 to 400 milliseconds, it starts closing here, and then the sphincter starts contracting, but it's already closed as it is still relaxed. That means the muscle pressure is still low, but the lumen has already closed. And this activity is, as I said, extremely coordinated and is there only to prevent this. Entire coordination is done to prevent aspiration. I won't get into the more complications of the upper esophageal sphincter and move directly into the esophageal body. Now, the esophageal body is again composed of two types of muscles. There is the longitudinal muscle and the circular muscle. I will not be discussing the skeletal muscle, which is right at the beginning, 5 centimeters, but come directly to the smooth muscle. Now, this is a study done way back in 2008, where the longitudinal and skeletal circular muscle contractions during peristalsis and TLESRs were shown. And what we know from many of these studies, this was of course a little later study, that the longitudinal muscle begins to contract as soon as the swallow is initiated and crosses the upper esophageal sphincter. As a result, the esophagus and the part of the LES actually move upwards. The esophageal musculature thickens and the muscle starts relaxing. Now, at these points, the bolus, if you notice, this is the contraction of the esophagus, and this is the bolus. The yellow is the bolus of food, which is in front of the contractile segment. Now, this is, of course, a later study, but when we go back and look at how manometry was, we did these kind of studies and saw pressures, and this is the current manometry. This you see here is the upper esophageal sphincter opening. There's a deep breath just prior to that. You see this dark blue segment here. As soon as the upper esophageal sphincter starts opening, the lower esophageal sphincter starts relaxing, which means it's still not open, but it is relaxing. And by the time the peristaltic wave reaches the lower end, the lower sphincter has already opened and begun to close. These studies also told us that the bolus was actually temporally in front of the peristaltic segment. So the movement of bolus became an interesting point when we realized that the bolus itself caused many changes, except and peristalsis was only one of the features that we were studying. So movement of bolus was studied with two correlation with two other parameters, that was radiology and impedance. And we look at this. This is a picture I borrowed from Mark Fox in Switzerland. So you see this manometric catheter on the right during a barium study. And simultaneously, this is the peristaltic wave. So when the marker is placed at the upper esophageal sphincter, the upper esophageal sphincter has started to open, and you find that there is no barium in the esophagus. As we go down, we've come at a point where the peristalsis has not yet started. This is in the transition segment between the skeletal and the smooth muscle. At this point, the peristalsis has not yet started, but the bolus is already coming into the mid-esophagus. As we move down further, we see that the bolus is coming into the lower esophagus. And as we go down, we see that while the peristaltic wave is still ending, the bolus is already in the stomach. Now, as I said, this was simultaneously done along with radiology studies. Subsequently, when we started using impedance, there were studies about impedance being used as an adjunct to high resolution manometry. Just a moment. Just a moment, my battery is going to die in a minute. Sorry. So therefore, impedance started getting used here. And on the basis of this, there was a combination of pressure and flow that the correlation between pressure and flow came up. So this is about impedance and admittance. Now, admittance means that, admittance means that the bolus is, rather that the lumen is allowing the bolus to be admitted, which means that the lumen is now opening. So original study showed that when you take impedance, that is the Z value of impedance, and the cross-sectional area, the correlation is not a linear correlation. But when you take the inverse of impedance, which means when the impedance is lowest, the lumen is wide open, but also, and so the inverse impedance is high, the lumen is also open, and the cross-sectional area of the esophageal lumen is high. And these studies allowed us to understand a little more about the peristalsis in the esophageal body, rather than what we thought was only a peristatic wave that pushed the esophageal bolus ahead. Okay, now what's happening? Oh, sorry. So this was one of the first few studies done, and this was, the lead author here was Dr. Ravi Mittal, whom we have on the panel today. What I have not shown here is that there was simultaneous intraluminal ultrasound done as well. So you see the same picture about the esophageal peristalsis, that the esophagus is contracted. The bolus is in front of the esophageal peristalsis. Now, wherever there is the bolus, this is the inhibited segment. Wherever there is the contraction is the contracted segment. And if you look at the cross-section of the muscle, you find that the cross-section of the muscle is maximum at the point of contraction, but the esophageal pressure is the distension of the esophagus is maximum at the point of the bolus. Now, based on this and a few other studies that came up later, the group from Chicago actually divided the phases of esophageal transport. That means starting with the smooth muscle of the esophagus up to the lower esophageal sphincter into 4 phases. The first is the phase of esophageal accommodation. I'll show you pictures of this. Then compartmentalization, peristalsis and esophageal emptying, and what happens after the peristalsis. And here it is. Again, please don't go by the colors and the complications. So you see this purple is impedance. For those who read solid state manometries, purple is the color of impedance and tells us the flow of the bolus as it goes down the esophagus. So right in the beginning, when the upper esophageal sphincter opens, there is esophageal accommodation. And as you see in the lower bar, which is the barium, you find that the upper esophageal sphincter has opened, the bolus is here, and the pressure at this point in the esophagus has actually dropped. Then there is esophageal emptying here, that the peristalsis is after the esophageal emptying, and this is the bolus is already reaching the stomach, and in the end there is the ampullary empty. So something like this, that right here, this is the domain of the bolus, and this is the domain of the contractile segment. And a combination of these is what helps the bolus to be transmitted from the esophageal body into the stomach. This is another complicated one, which says almost similarly that the pressure will increase much later. This is the peristaltic wave that you see during manometry. And this is the cross section of the lumen. That is, the lumen is opening long before the pressure wave has started. I won't go into this because this will take up a lot of time. So the factors that influence transfer of food across the esophageal body lumen is the intrinsic active components, which is the esophageal striated muscle excitation initially, followed by smooth muscle inhibition and excitation. And at the same time, just as the smooth muscle is being inhibited, the LES is already inhibited and then gets excited when the bolus has passed through. The extrinsic active components are the crural diaphragm excitation. The passive components are the luminal geometry, which means the luminal opening and closing, and the wall compliance, which I'm sure when talking about pathogenesis of symptoms and dysphagia, wall compliance will come into play. And of course, there are extrinsic elements which may compress the esophagus, like the heart and the blood vessels. So in conclusion, swallowing occurs in 3 phases. And the aim of the swallowing process is to transfer food from mouth to stomach. It aids in nutrition. The upper esophageal sphincter, as I said, is the door to the esophagus. Its job is to prevent aspiration while allowing swallowing at the same time. The esophageal body had 4 phases of transport, and the lower esophageal sphincter prevents reflux and allows food to pass from the esophagus into the stomach. Thank you.
Thank you, madam.
I hope it wasn't too complicated, Rajesh.
No, I think it was fine, ma'am. Can you stop sharing the screen so that we can invite the next speaker? We'll have questions at the end. Monish, will you go ahead and introduce our second speaker?
Good evening. Good evening, everyone. It's my proud privilege and honor to introduce the next speaker, Dr. ANIL ARORA. And he doesn't need any introduction. He is one of the leading gastroenterologists and hepatologists of the country, and is currently the chairman of gastroenterology and hepatobiliary sciences of Gangaram Hospital in New Delhi. And he is going to speak on pathogenesis of common swallowing disorders. Dr. Arora, please.
Thank you, Manish. Are you able to see my slides clearly?
Yes, sir.
Okay. So what I am going to, after an excellent presentation by Professor Shobna Bhatia about the mechanisms of the normal swallowing, I'm going to talk of what makes it abnormal. That is pathogenesis of the commonly encountered esophageal motility disorders. Just to recapitulate 3 important components of the normal pathophysiology of the esophagus. Upper 1/3 is made up of the skeletal muscle, distal half is made up of the smooth muscle, and then you have a transition zone in the esophagus in which you have a combination of the two. So the upper esophagus is lined by the striated muscle, lower esophagus is lined by the smooth muscle, and in between you have a combination of the two. This is important because you have 3 different components of esophagus. Upper esophageal sphincter, which he has already talked about. Then you have the body of the esophagus, and then you have lower esophageal sphincter. Lower esophageal sphincter is within the diaphragmatic hiatus, and the esophageal body ends in a 2 to 4 centimeter length of asymmetrically thickened circular smooth muscle known as lower esophageal sphincter. This typically is contracted at rest, creating a high pressure zone. As Professor Bhatia very rightly mentioned, the main purpose is to prevent the back reflux of the food up into the esophagus. So a combination of the diaphragm, the different oblique and the sling fibers from the G junction, and the smooth muscle, which is tonically contracted at the lower end of the esophagus, gives a composition of lower esophageal sphincter. In fact, before understanding the basis of pathophysiology, we have to remember 2 major innervation of the esophageal wall. You have 2 types of plexuses which innervate the esophageal wall. The one between the outer longitudinal and the inner circular muscle is called Myenteric plexus or Auerbach's plexus. The plexus which is in the submucosa is called the submucosal plexus or Meissner's plexus. It is important to understand that most of the motility disorders will be released and will be affected by the alteration and the pathophysiology which occurs in the myonteric plexus and not in the submucosal plexus. Submucosal plexus is extremely irrelevant in esophagus because it has more to do with local secretion and absorption, which has more to do with the stomach and the small bowel rather than the esophagus itself. So this is what happens. You have outer longitudinal muscle, you have inner circular muscle. In between the two, you have the myonteric or orbex plexus, and then in the submucosa, you have the Meissner's plexus, which does not have any relevance so far esophagus is concerned. Another important aspect, which is again at the verge of repetition from what Dr. Shobna has told us, is that the vagus nerve supplies two types of fibers. The one in the proximal esophagus, that is in the striated muscle, has only cholinergic innervation. But the smooth muscle in the lower end esophagus has both. It lands up in the myonteric plexus onto the ganglion, and we have two types of postganglionic fibers. The excitatory fibers release acetylcholine, and inhibitory fibers release nitric oxide and VIP, that is vasoactive intestinal peptide. Another important component of anatomy to remember before we start discussing the pathophysiology is that the upper esophagus, when a bolus comes into the oropharynx and is typically crossing the upper esophageal sphincter, has a sequential peristaltic wave which starts in a manner in which there is innervation from the nucleus ambiguous. Subsequently, as the bolus travels into the lower esophagus, you have the innervation which is coming from the dorsal motor nucleus, which has two types of innervation. As against only the striated muscle having acetylcholinergic or excitatory neurons, you have both relaxation of the esophageal smooth muscle by the nitric oxide producing neurons and excitatory neurons, which are supplied by the acetylcholinergic nerves. So this is important to remember that the lower esophagus is supplied more by non-cholinergic or nitric oxide producing neurons as against the cholinergic or the excitatory neurons in the upper esophagus. So what is peristalsis? As Dr. Shobna said, I think it is important to remember and memorize every single component of what is normal peristalsis. It should be progressive, it should be sequential, it should be unidirectional, it should be involuntary, it should be symmetrical, it should have both muscular contraction and relaxation, and its purpose should be to push the bolus distally. Only if all the components of this are satisfied do we call it a regular primary peristalsis. In fact, when we talk of abnormal or normal peristalsis, we should understand there are three types of peristalsis: primary, secondary, and tertiary. What is a primary peristalsis? As Dr. Shobna said, the very act of swallowing initiates this reflux. That means food comes into the upper esophagus. There is a contraction because of the innervation by the nerves coming from the medulla oblongata. The distal esophagus accommodates and relaxes to have the incoming food bolus, which distends the esophagus, which subsequently contracts. The distal part relaxes, and in a sequential manner, you have a food going down with all the components which I've shown you. So this is what is a primary peristalsis. It is a sequential, it is a persistent, it is progressive, it is directed caudally only. So it is induced by swallow-induced peristalsis called primary peristalsis. What is a secondary peristalsis? Secondary peristalsis occurs not because of the innervation from the brain as happens in the primary swallowing, but it occurs because of the two reasons. One is there may be leftover food in the esophagus, which leads to stimulation of the esophageal muscle to push the bolus down. And secondly, there may be upcoming food from the stomach up into the esophagus, which needs to be cleared. So the remnant food in the distal esophagus or upcoming food from the GE junction leads to something called secondary peristalsis. And what is finally a tertiary peristalsis? Again, we should remember it is non-progressive, it is irregular contraction, it is isolated or repetitive, it is spontaneous or in response to swallowing. It does not have a physiological role. It is seen more in elderly. In fact, if you have to see it, it is just like having tremors in the hand. Tertiary peristalsis does not contribute more. Just to give you an analogy, that other than having shivering and trembling, it doesn't give you more information than that. So what is the pathogenesis of motility disorders? In fact, we attribute it to the neuromuscular dysfunction, which occurs because of the problems of swallowing, and clinically the symptoms may be in the form of dysphagia, chest pain, regurgitation, and heartburn. Let's try to dissect out as to why do these patients develop dysphagia. Whenever the patient has symptoms, it may occur because of the distension. You have a mechanoreceptors which cause esophageal pain and discomfort. You have mechanoreceptors which, because of the excessive distension, may lead to ischemia and present as pain. And then certainly we will have chemoreceptors occurring because of the upcoming acid into the lower end of the esophagus. There is a transmigration of the acid from the subepithelial loose junction into the submucosa, irritating the nerves in the Meissner's plexus. So a combination of these, mechanoreceptor stimulation, ischemia, and the chemical injury, produces typical symptoms of the dysphagia, heartburn, regurgitation, or chest pain in the center of the chest. What is heartburn due to? It may be related to esophageal hypersensitivity, decreased vagal tone. Mind you, once you have a prominent and important vagal tone, it typically has an anti-nociceptive action. And whenever the vagal tone decreases, you are more likely to have a nociceptive stimuli, or more likely to come down with symptoms of the pain and discomfort in the setting of esophageal motility disorder. So also there is some suggestion to show that there is an alteration in the neurological mechanisms leading to increased release of the mast cells and tryptase and histamine, which aggravate these problems. But coming on to the primary esophageal motility disorders, by the Chicago classification, we try to define them as hypomotility disorders or the hypermotility disorders. Hypermotility disorders are primarily in the form of achalasia cardia or ineffective esophageal motility, and hypermotility are primarily in the form of diffuse esophageal spasm, jackhammer esophagus, and hyperperistaltic esophagus. There have been various versions of the Chicago classification. The currently followed version is the one which was released in 2020, again trying to characterize the diseases as esophageal gastric junction, EGJ, outflow obstruction, or disorders of the peristalsis, which will be coming to one by one. These are the definitions of how we define the various types of EGJ obstruction, which I think Dr. Ravinder Mittal will be talking to us in detail. Suffice it to say that there are two major problems of motility for which we have to understand the pathogenesis. The one is the disorders of peristalsis in the form of absent peristalsis, distal esophageal spasm, or jackhammer esophagitis, or else ineffective esophageal motility, and we'll come one by one as to what happens. Let me come back to the basic anatomy of how the esophagus is innervated. So esophagus is primarily having both mesenteric as well as the mesenteric plexus of the nerves. In what is important for us for understanding the pathophysiology is this mesenteric plexus, which is innervated not directly by the vagus nerve coming from the dorsal motor nucleus, but it lands onto the preganglionic fibers. These preganglionic fibers tend to have two postganglionic fibers, the one which leads to excitation of the nerves. Both of them land up onto the motor end plate of the smooth muscle. So if you have excitatory neurons in the form of acetylcholine, you will have contraction of the muscle, and if you have excitation of the neurons which releases nitric oxide or VIP, then you will have relaxation of the muscle. The basic problems lies in achalasia or motility disorders, in this destruction of the so-called nitric oxide or vasodilatory producing or smooth muscle relaxant producing neuron. So this is what is primarily affected in patients with achalasia cardia. The basic problem in patients with achalasia cardia is that you have a destruction specifically and typically of the distal esophageal neurons which secrete the nitric oxide. So there is an imbalance in the inhibitory neuronal activity producing neurons, that is VIP and NO, thereby leading to excitation of the counteracting neurons which produce acetylcholine. So the imbalance between acetylcholine producing neurons and the destruction specifically of the nitric oxide producing neurons is what leads to this type of problems, primarily in the form of achalasia cardia. What is the trigger for this destruction of the nitric oxide producing neurons? It can be in the form of the common diseases which typically tend to occur in South America. In fact, the general prevalence of achalasia all over the world is 1 in 1 lakh cases. But if you go to countries like Mexico and South America, and Brazil, where Chagas disease is common, then up to 800 cases of achalasia cardia can be seen in the general population in 1 lakh individuals. Then there could be viral or HLA related factors which could be responsible for destruction of this nitric oxide producing neuron in the myonteric plexus of the distal esophagus. So once there is an insult, there is inflammation in the myonteric plexus that leads to destruction of the neurons, leading to the classical achalasia cardia. So destruction can occur both at the level of the LES as well as at the level of the distal esophagus. If there is a destruction of the nitric oxide producing neurons in the LES, you will have a hypertonic LES leading to increased IRP. So that will be presenting typically as EJJO or achalasia. However, if there is a effect of this inhibition of the inhibitory neurons in the distal esophageal body, you will have inflammation and spasm of the distal esophagus. Let's see how it translates into clinical practice. So this is what happens in patients who have, this is the normal esophagus. So the distal esophagus has more inhibitory neurons, whereas proximal esophagus has more excitatory neurons. So red indicates inhibitory nitric oxide producing neurons, whereas the green indicates the excitatory or acetylcholine producing neurons. The disease in achalasia cardia progresses from lower esophageal sphincter up into the proximal esophagus. Let's see what happens. Let's talk of EGJO. That means this is a disease entity in which there is a only destruction of the nitric oxide producing neurons in the LES. So what happens is the distal esophagus is spared, proximal esophagus is spared, striated muscle is spared. So typically what happens is you will have a patient who just has a raised IRP but normal peristalsis, which is understandable because this is intact, this is intact. So the problem lies in specific destruction of the nitric oxide producing neurons in the LES. So this is what happens. This is the classical EJJ. There is no relaxation of the lower esophageal sphincter. Peristalsis is maintained. This is the classical EJJ. Coming on to the next entity in which there is a combination of destruction of the LES nitric oxide producing neuron coupled with inflammation in the myonteric plexus. Once you have inflammation in the myonteric plexus, that leads to excitation of the acetylcholine producing neurons in the postganglionic region, coupled with destruction of the nitric oxide producing neuron. So persistent stimulation of the acetylcholine producing postganglionic fiber leads to premature contraction. So you have a combination of a disease in which there is increased LES pressure or increased IRP coupled with premature contraction. That is a classical achalasia cardia. So the lower esophageal sphincter fails to relax, whereas the distal body reacts completely and there is a premature contraction. So that is a classical type 3 achalasia cardia. That means you have persistent rise in LES, that is IRP is elevated, and you have a premature contraction, which is defined by the latency of less than 4.5 seconds. Coming on to the next stage as to what happens. Suppose there is a progressive destruction of not only LES, but also the distal smooth muscle. So you have injury of the NO producing nitric oxide producing postganglionic fibers. So that leads to destruction of the LES as well as the distal smooth muscle. So what is left is a proximal esophagus, which has a lot of excitatory or acetylcholine producing neurons. So since the food in any case is coming from above downwards, so we are making the body makes an excellent attempt to push the food bolus down. So this leads to a non-sequential pan-esophageal pressurization or PEP. This PEP coupled with increased IRP is the classical setting for type 2 achalasia. So is it that we are evolving from EGJ to type 3 achalasia to type 2 achalasia? This is classical. When you have PEP coupled with failure of relaxation of the lower esophageal sphincter, raised IRP. And finally, we come to a stage in which not only there is a destruction of the nitric oxide in the LES, but the distal esophagus is gone because as the nitric oxide is not produced, same thing ascends up into the proximal smooth muscle. So there is no smooth muscle to push the food down into the stomach. So that leads to classical aperistalsis. So you have a combination of non-relaxing lower esophageal sphincter, no activity of the muscle in the body of the esophagus, and you have a classical type 1 achalasia cardia, raised IRP, and complete aperistalsis. So, so to summarize, what is EGJ? You have a combination of just EG, esophagogastric junction obstruction, which can result in type 3 achalasia. This may proceed to type 2 achalasia because now you have more and more attempt on the part of the distal smooth muscle of the esophagus to push the bolus across the G junction into the stomach, and finally you may land up at a time when the whole muscle has got fatigued and there is a persistent obstruction at G junction. Coming on to the second mechanism of motility disorder, that is the hypermotility disorder, diffuse esophageal spasm. Now this entity has been renamed as distal esophageal spasm. The reason is you have a destruction specifically of the nitric oxide producing neuron in the distal esophagus. So this entity is now not called as a diffuse esophageal spasm, but it has been referred to as distal esophageal spasm. This again occurs because of the different theories which have been propounded. The basic concept is that there is a specific destruction of the nitric oxide producing neurons in the lower end of the esophagus where the lower esophageal sphincter is spared. So this is a classical setting in which there is a premature contraction at the lower end of the esophagus, preventing the passage of the food into the stomach when LES is not tight. So this is not called diffuse esophageal spasm. This is the distal esophageal spasm. And how do we see it? That in distal esophageal spasm, what happens is that you have acetylcholine producing neurons which get hyperactive in the distal esophagus because of the decreased counteraction by the nitric oxide producing neurons, which are becoming dead in presence of a normal LES. So this is what typically happens. So you have a normal relaxing LES, but there is a premature contraction, that is a distal esophageal spasm. And finally, because of the different reasons, if these spasms are too frequent, if they are too high in intensity and amplitude, then you have a classical nutcracker or jackhammer type of esophagus, in which again the IRP is normal, there is normal distal latency, but fortunately and unfortunately, the peristalsis is pretty robust. We still do not know why it happens. There are various theories which have been propounded, like obstruction at the LES, myocyte hypertrophy, or neurogenic problems occurring within the mesenteric plexus in the form of increased histamine and tryptase, or there may be eosinophilic infiltration which stimulates repeatedly the acetylcholine producing neurons, resulting in jackhammer esophagus, in which again classically you will have a normal IRP but grossly exaggerated esophageal contraction producing pain and dysphagia. And finally, you will have ineffective esophageal motility, which is defined by DCI of less than 100 is called failed peristalsis, or anything between 100 to 450 is called weak peristalsis. Ineffective peristalsis again occurs because the destruction of the acetylcholine producing neurons, which can occur both in the distal as well as in the proximal esophagus, because both pre and the postganglionic fibers are known to produce acetylcholine as a neurotransmitter. This is the classical ineffective esophageal motility. There is a relaxation of the LES, but if you see, there is no continuing wake of the peristalsis to take the food down. Another example of almost aperistalsis in this patient with normal IRP. Fragmented peristalsis is no more considered as a separate entity, and now it is supposed to be a part of the ineffective esophageal motility in Chicago 4 version. To sum up, ladies and gentlemen, we still are understanding the nuances of pathophysiology of esophageal motility disorders. To end up, I'll just have this quote: there is always a hope and an end. It depends on us how we deal with them. We can look it as a hopeless end or as an endless hope. Let us start looking as an endless hope. With that, I'll end up my presentation and hand it over back to the moderators.
Thank you very much, Dr. Arora, for an excellent talk in explaining us the pathogenesis of various motility disorders. And I think we can have the discussion at the end. And I'd like to call Dr. Rajesh to introduce our third speaker of the day.
I'm very happy to introduce our third speaker, Professor Ravinder Mittal from United States of America. He's a board-certified gastroenterologist with special interest in gastrointestinal motility. He's the professor of medicine at UC San Diego. He's got multiple clinical and research publications and interests in gastrointestinal motility, some of which Dr. Shobna Bhatia has so kindly shared with us, and with special interest in swallowing disorders and esophageal disorders. Welcome to you, sir. Good morning to you, and thank you for joining us.
Thank you, everybody. It's great to be there at this meeting. I remember Gangaram Hospital. I used to drive by. I lived in Indapuri and Maulana Azad. I remember often driving by Gangaram. Then I realized, where is the origin of the Gangaram? I guess I'm getting older. I'm getting more interested in the history. And once I was in Lahore, and I found out that actually the origins are in Lahore. So anyway, this brings a lot of memories, and thank you for your kind invitation, and thank you for the excellent lecture, Shobhan and Dr. Garg, Anil Arora. I think you guys made my job easy, so I really don't have to tell you anything. So what I'm going to share, a couple of things, my thoughts. All that needed to be said is already said. So a couple of thoughts here. So my task was classification of the swallowing disorders. And this is on the eve of this Chicago classification. I don't know whether that was in the mind of the organizer. That Chicago 4 classification has just come in, published, and I see a lot of Indian names in there. Shobha is there, Uday, Ghoshal, Sumit Mittal, and of course I'm there as well. So it's a proud thing that so many people are involved. So just a little bit on this. So I'm going to go a few slides on what has been published, and I think it's good to know the protocol. I'm trying to get rid of this thing. I'm having trouble how to get rid of this bar there. But anyway, I don't know. Maybe I can get rid of this bar. But so what is this bar? Does anybody know how to get rid of the bar?
I think you can restart, sir. You can stop sharing and get back. Yeah, you can stop sharing and then get back again.
Stop sharing. So new share. If I do the new share, huh? Yeah, it comes back right there. If I close this here, maybe one is gone. This other bar, I don't know how to get rid of. But anyway, so this is the current protocol to do the manometry studies. So after you place the catheter, so you give a little bit of 60 seconds of rest, then you do 3 deep breaths. Can other people please mute? I'm hearing noise there. So you do 10 swallows, then you do some rapid swallows. You guys can hear me, right?
Yeah, we can hear you.
Okay. So you do 10 5 ml swallows, then you do rapid swallows, and then you have the person sit up. Then you do 3 deep breaths to confirm your position again. And then you do 5 wet swallows, and then you do a rapid drinking challenge, and then you take out the catheter. So I think there is a reason for this protocol, and I think one of the things that all the manometry labs should standardize the protocol. Now, one thing I want to point out is, how do you know that the positioning of your catheter is correct? Well, that's why we do these 3 deep breaths. So this tells you that this is the lower esophageal sphincter there. And when you take a deep breath, the pressure increases in the sphincter. And then, this is the stomach, esophagus, upper sphincter. So you position correctly. So I think the positioning is very important. and then you follow this simple protocol. And I think Chicago classification is based on some of these findings on this protocol. Now, what happened there? Why is not going down? It's not going down. Sorry, guys. I'm sorry. Oh, here. Let me try a new share. Sorry. Usually, I thought I had learned everything about this thing, but maybe I have not. Who is the technical master here? No questions.
Sir, you can just restart your PowerPoint. I think that will be the easiest.
You can close down your presentation and restart. I think most of the time it will work.
So just clicking on this is not working.
If it is hanging, you can just use escape button, get out of PowerPoint, close it, and then restart.
Escape is not working either.
Ravi, you can put off your presentation completely. Stop sharing the screen. You've already done that.
Let me see.
Yeah, so you stop sharing, close your presentation and restart it.
No, everything is gone dark here. Okay, sorry. Hopefully this will work. So what are we looking for? So just a little, I mean, this has made life so much easier. You know, we used to read these pressure waves, but this high resolution manometry and color topography has made life so much easier. Basically, we are looking at three key parameters of peristalsis in the Chicago classification: IRP, distal latency, and distal contractile integral. So what is that? So
Your
normally,
slides are not visible, sir.
Your slides are not come
You've
through.
not started sharing the slides.
you would think I should have known. I do this Zoom meetings every day, 10 times a day. But it's failing me. Now the Zoom has disappeared here. Let's see here. New share. Do you see that? You see the slide?
Yes,
Yeah.
Ravi, we see that you have started sharing your screen.
So now if how about that? How about that?
No.
You don't see the
Yes.
screen?
We can see it. We can see
Fantastic.
it.
Yeah, this is good.
Okay.
We go to
Okay.
presentation mode.
Full screen.
No, presentation.
I'm sorry?
Presentation. You're right.
Yeah, I'm in the presentation mode. So these are the three key parameters: IRP, distal latency, and distal contractile integral. You guys already know that with the onset of the swallowing, you know, it takes a certain time for the contraction wave to reach the distal esophagus, and the time it takes is called distal latency, now 4.2 seconds. And then you have these the low
We seem to have lost you, Professor Mittal. We cannot hear you.
Dr. Rajesh, Dr. Manish, if you permit, can we come back to him and start with Shri Hari, and then we can come back to him once the issues are sorted out?
Sure, sir.
We can do that.
we can do that. But
But,
yes,
he's continuing to share the screen. So somebody from technical, somebody who's the host, I don't know
Yeah.
if you can.
Can you hear me? I logged
you're
in
back.
again.
yeah, we can hear you, sir.
Professor Mittal, should we allow the next speaker to speak until then you can just
No, let's see.
something?
Let's see. I'm here. Can you guys see this now? Can you see?
We can see, sir.
Yeah, we can.
Okay. So just confirm one more time. You guys can see?
Yeah.
Yes, sir.
Yes, sir.
Okay. So I talked about this distal latency, IRP, and then DCI is the distal contractile integral. It integrates the value of the pressures, and normal DCI is less than 5,000. Normal IRP is less than 15, and the distal latency is less than 4.2 seconds. So based on these three parameters, I'm just going to show you certain of these how these patterns look like. With this color topography, life has become so simple. I think a high school student can probably pick up these major motility patterns so easily. So this is achalasia esophagus. And again, I took this from this paper on the new Chicago classification. Type 1 achalasia, where the key parameter in all of this is that the lower esophageal sphincter doesn't relax. And then you don't have peristalsis in all of them. And the difference is in how the esophageal contractility looks. In type 1 achalasia, there is no contractility, very little in the smooth muscle portion. Type 2, you have what we call the pressurization of the esophagus. And of course, lower esophageal sphincter doesn't relax. IRP is greater than 15. And in type 3 achalasia, I have a little different opinion on that, whether these contractions are peristaltic or not, but I'm not going to let that come into this talk, that whether this contraction is peristaltic or not, but this is what type 3 achalasia is. The lower esophageal sphincter doesn't relax, and there is simultaneous onset of the pressurization wave. So one of the important thing I think in this new Chicago classification that they have pointed out is that sometimes, the things may not be precisely the same as you expect. For example, this is one achalasia esophagus where the lower esophageal sphincter pressure is not high. And there is no pressurization in the esophagus, but if you look at the IRP, it doesn't meet the criteria for less than 15, or more than 15. The IRP here is 7.6. So important thing is the supportive testing. And I always emphasize my students, any fellows or trainees or anybody that comes through my lab is, you cannot make an esophageal diagnosis of motility disorders just by the manometry alone. You need to look at some other things. Barium swallow is very important. And in this case, you see the narrow GE junction, dilated esophagus. And recently, this endoflip technique, I think, is a good technique to look at the distensibility of the lower esophageal sphincter. And you will find that even though the pressure is low, but the distensibility is low, unlike normals where the distensibility should be high. So keep that in mind. Just don't get carried away with manometry, even though everybody thinks it's a gold standard way to make the diagnosis, but it's really, you need supportive other testing as well. Okay, so this is outflow obstruction. Then outflow obstruction can be many types. So outflow obstruction means that your IRP is greater than 18 or greater than 15. And then what happens in the body of the esophagus along with this high IRP, like in achalasia, we said that there is no peristalsis. But in these other types, that there is peristalsis. That's what it differentiates from the achalasia esophagus. So this is EGJU, esophagogastric junction outflow obstruction, or impaired LES relaxation, you can call the many types. hypercontractile features. This looks like no evidence of disordered peristalsis. And this one is you got to be aware of. Sometimes you can get it, some artifacts in these recordings. And that's why you got to do your recordings in different positions to confirm whether it is real or there is some issue with that. Now, if you have normal lower esophageal sphincter relaxation, you can just have isolated problems of the esophageal body. So for example, this one is absent contractility. So IRP is normal and there is no contractility in the esophagus. Normally I see that in scleroderma esophagus or bad reflux esophagitis, you can see this. Same thing here, ineffective esophageal motility, where you see the DCI of less than 450 and normal IRP. Ineffective esophageal swallow, meaning fragmentation, more than 5 centimeter segment is missing. So that's called fragmented peristalsis. And this is contractile augmentation following multiple rapid swallows. So normally after multiple rapid swallows, you should see augmentation or a stronger contraction wave. And in reflux disease and scleroderma, or sometimes this augmentation is lost. Then comes these disorders where the IRP is normal, but you have problems localized to the body of the esophagus. So one of the things we look in the body of the esophagus is the latency, distal latency. So normally distal latency should be more than 4.2 seconds. Here is 3.2 seconds. And along with that, we look at the DCI more than 5,000. So this is esophageal spasm. This is hypercontractile, where this is jackhammer esophagus, DCI of more than, this is nutcracker, this is jackhammer, DCI more than 10,000, and the waves are repetitive. And this one here is the hypercontractile, but this is localized to the distal esophagus and the lower esophageal sphincter region. So this is a hypercontractility. We can give it different names: this diffuse spasm, nutcracker, jackhammer, hypercontractile lower segment. So I think it's good that we, with the Chicago 4 classification, we have a uniform way of classifying these disorders. So this is the summary of how do we classify these things. And this is based on 10 wet swallows. You look at whether the sphincter is relaxing or not. And then you look at whether you have problem with peristalsis. So if you have both of these, you have problems with the sphincter relaxation and you have problem with peristalsis 100% of the times, then it is achalasia. On the other hand, if peristalsis is relatively preserved, but the sphincter is not relaxing, then it is EGJU, or esophagogastric junction outflow obstruction. Disorders of peristalsis without the sphincter problem, I showed you absent contractility, distal spasm, hypercontractile esophagus, and ineffective esophageal motility. So, what this Chicago classification has provided has precise parameters based upon which you can make the precise diagnosis. But does it really mean that is there precise therapy for precise disorders? So that is for another issue. And then there are differences in the, so just to point out that Chicago 3 versus Chicago 4, there are some minor differences in terms of the classification. But from my point of view, I think the most important thing is look at the patient's symptoms. Symptoms of all these motility disorders. You don't want to make a diagnosis just based on the motility disorder. You've got to go and talk to the patient and figure out what is the precise symptom, and then look at your manometry, not the other way around. And look at whether this outflow obstruction is relevant or not by looking at the symptoms, dysphagia, pain, and then you want to do more confirmatory tests. Like I said, esophageal manometry or Chicago classification, yes, it's the best we have, but it cannot, or it should not, or it totally does not help you with predicting or making the precise diagnosis. You got to go and talk to the patient, and you got to go and look at some other barium swallow endoscopy and other things. So again, whether it's distal esophageal spasm is relevant or not, you got to look at the patient's symptoms, symptoms of dysphagia again for hypercontractile esophagus. So I think, I cannot overemphasize of going and talking to the patient. Manometry is great. It's beautiful color plots, it's high tech, and that's all good. And one of the things, if you read the paper, is there are important messages embedded in the Chicago classification. And I just said it, but I'm going to repeat myself here, that manometry study should be interpreted in context of the patient's symptom. You don't want to treat a motility disorder just based on the manometry, what is it showing you? You got to go and treat the patient. Manometry alone does not provide all the answer to patient symptoms. Manometry in conjunction with other esophageal function testing is often needed, such as endoscopy, barium swallow, CT scan, ultrasound imaging, endoflip testing. So these are all ancillary, important, corroborative, I should say, testing that could help you arrive at the diagnosis correctly. And one thing I'm just going to show you for a few minutes, the most actionable item in the treatment of esophageal motility disorder is the esophagogastric junction. Whether it is myotomy, Botox, fundoplication for reflux disease. For esophageal peristalsis, we have very little pharmacotherapy and POEM surgery. Now we learned that Heller myotomy alone is just not good enough to treat achalasia 3 esophagus. You need to extend the myotomy to the aortic arch, long myotomy. In the good old days, the treatment for diffuse esophageal spasm was long myotomy, not just Heller myotomy. So I think that's an important thing. But for most of the other disorders, the actionable item is the esophagogastric junction. So why is the esophagogastric junction so important? Well, this is the review that I just wrote in the New England Journal. And one of the things that I have been focused on the wall of the esophagus. And one of the things, hallmark of all motility disorder is the hypertrophy of the esophageal musculature. So if you look at these ultrasound images, you see this, normally these circular and the longitudinal muscles are quite thin, less than 1.5 millimeter. But in all motility disorders, whether it is distal esophageal spasm, whether it is nutcrackers, whether it is achalasia, there is hypertrophy of the esophageal musculature. So a lot of emphasis on these motility disorders is on the enteric nervous system, degeneration of the inhibitory neurons or excitation of the excitatory neurons. But I believe that another major problem is the muscle itself. It's hypertrophied or it's atrophied, which is not emphasized in the pathogenesis. And the reason I emphasize it, I believe that this is based on my 30 years of work, that fundamental problem in all motility disorder is actually the lower esophageal sphincter. Why do I say that? I like this analogy of the heart. If you have aortic stenosis, the first thing you're going to see is the hypertrophy of the left ventricle, increase in the thickness of the left ventricle. And then towards the end, you will see failure with dilation. And I suspect this is the same thing happens in response to obstruction. The first thing is the hypertrophy of the esophageal musculature. And then this is type 2 or 3 achalasia esophagus or spasm or nutcracker. And then you have ultimate failure where the esophagus starts dilating, and this is type 1 achalasia. So again, this is a little bit of a speculation, but I believe in it. And the reason I think is because the actionable item is the lower esophageal sphincter, where you can do something about. So another thing that I want to emphasize, and Shobha mentioned that, is LES, relaxation and distensibility. So there are two functions of the lower esophageal sphincter. We always talk about relaxation, and manometry measures the relaxation. It does not measure the opening function of the lower esophageal sphincter. Now, what is relaxation and what is opening? I should have brought in another slide, but I didn't put it in. So relaxation is what is measured by manometry. And you can have 100% relaxation, but your luminal diameter may still be the size of the manometry probe, which is 4.5 millimeter. In order for the bolus to go through the sphincter has to open up to at least 15 millimeter or more. And that's not what's measured by manometry. And that's a lot of people don't understand. The manometry just measures relaxation, but equally important is the opening function of the lower esophageal sphincter. And one of the techniques that has come out, endoflip testing, that tells you the opening function. And based on endoflip testing, and this is not my data, this is the data from Northwestern Group, who published a lot of stuff. If you look at the distensibility of the lower esophageal sphincter, whether it is type 1 achalasia, type 2 achalasia, type 3, Agnew, jackhammer, nutcracker, doesn't matter. The distensibility of the lower esophageal sphincter is impaired in all spastic motor disorders of the esophagus, except maybe not all, but even in some of these ineffective esophageal motility disorders. So the sphincter is the most important fundamental abnormality, I believe, in motility disorders of the esophagus. Then I want to briefly touch on normal motility. So this is the old data, traditional manometry technique. If you do the manometry study in patients with dysphagia, I'm just going to focus on dysphagia, half of the manometries are normal. So this is what I was saying, that normal manometry, does it really mean patient doesn't have dysphagia? Or does it really mean the patient is kind of psycho or is functional or something? So this is an important group of subjects that have dysphagia, but our manometry studies are normal. This is based on the old system. Now, even with the high resolution manometry system, 23% are normal. I believe there are more than 23% are normal, but at least a large number of patients. So what exactly do they have? And this is leading to some of the work that we have been doing for many years. Shobna mentioned one slide of that, is this phase of peristalsis. So we only focus on the contraction phase of the peristalsis, relaxation of the sphincter, IRP. But what is happening in this phase of the peristalsis? This is the phase of inhibition. This is where the bolus is going through the esophagus during this time. This is a 6-second time interval that is crucial, where the bolus is going through. And manometry does not measure that component of the peristalsis. The manometry only measures the contraction phase of the peristalsis. I think for the sake of time, let me just skip that. So there is another aspect of the esophagus that is very relevant. That is the distension, how well the esophagus distends before it starts to contract. So, this is just to show a lot of our work is based on the ultrasound imaging. And we look at the cross-sectional area during the distension phase. And you can see beautifully how with different size boluses, your cross-sectional area of the esophagus goes up. So you can measure with the ultrasound, but we figured out way how you can measure with the impedance. So impedance, what Shobna showed before, is normally used for reflux monitoring, bolus clearance, mucosal for integrity. But we have figured out a way, I'm not going to go into detail, how did we do that you can measure distension, how well the esophagus distends during peristalsis based on these impedance recordings. And now we are looking at these, what we call distension contraction plots. So this is what we normally assess in the Chicago classification, the contraction phase, how well the esophagus distends based on the impedance monitoring. We figured out a way to look at the amplitude of the distension and when is this distension occurring in relationship to the contraction. So this is, we're just looking in the normal people in the supine, viscous bolus, how it's going through the esophagus, how well it distends. This is in the Trendelenburg position. This is viscous in the Trendelenburg. So you can see beautifully what I call the distension contraction waves. And from this, you can build something like this. This is like a barium swallow, and you can see how the esophagus distends. So this is one swallow. These are the sequential images every 0.3 seconds apart during a swallow when the contraction is pushing the bolus. So this is the contraction wave behind, and this is the distension of the esophagus. You can see how the esophagus is distending in the supine position, and this is in the Trendelenburg position, contraction behind and the distension ahead, and you can see how the distension is moving, and you can quantify how well the esophagus distends. So in Chicago classification, we are only looking in the contraction phase, but what's happening in the distension phase has not been studied. And I'm going to show you a lot of our work is pointing that in a lot of people that come out normal on the manometry testing, the problem is in the distension phase of the peristalsis. Contractions may look good, but the esophagus is not distending. So this is an example of a normal subject, how well the esophagus distends. And this is a patient with nutcracker. Not a lot of nutcracker patients present with chest pain, but half of them also have dysphagia. And what we found was that the esophagus doesn't distend well in these patients. This is our data on functional dysphagia. This came out in Gastro a couple of months ago. This is normal distension, contraction behind. So functional dysphagia. What is functional dysphagia? Contractions are normal, but we found that the esophagus doesn't distend well in functional dysphagia. So these are some of the examples of looking at normal distension. This is in a patient with ague with dysphagia. It doesn't distend well. And then I don't want to go into detail today, that there is a problem in the temporal relationship between when the esophagus distends in relationship to contraction. And these distension contraction plots can tell you. This is in a nutcracker esophagus. This is somebody in a functional dysphagia is not distending well at all. So we believe that a lot of patients with dysphagia that come out normal on Chicago classification and motility study have abnormalities in the distension phase of the peristalsis. So just this last slide, I think the future, I just got to tell you a little future based on our work, that peristalsis by definition consists of two phases, initial inhibition followed by excitation. And the current scheme of classification is based only on the excitation phase of the peristalsis. And many patients with dysphagia have abnormality in the inhibition or the distension phase of peristalsis. And I think future classification will include both distension and contraction, hopefully in my lifetime, because these things take a lot of time. Chicago classification has been ongoing for last 15 years or 12 years. And how quickly we'll be able to incorporate this inhibition phase in the assessment of the dysphagia and motility disorders, I would like to see it happens in next few years. Thank you so much.
Thank you, sir.
Yep.
Munish?
Can you, sir, stop sharing your screen, please? Thank you. I think we move to the last talk of the session today, and it is by one of the young dynamic gastroenterologists from Sir Gangaram Hospital, Dr. Shri Hari Anikandi, who has a special interest in motility disorders and has been running a motility lab there. Dr. Shri Hari Khandi, and he's going to speak on clinical evaluation of dysphagia.
Thank you, sir, for that generous introduction. I hope you can see my slides.
Yeah.
Yeah. So after those wonderful, very loaded lectures from all the stalwarts, I am here to discuss a very a relatively more simpler topic, one that would be useful for all of us in the day-to-day evaluation of a lot of patients who present to us with dysphagia. So in the next few slides, I would like to make some comments about how to make clinical evaluation of a patient with dysphagia simpler. So whenever we have a patient with dysphagia, the complaint that the patient presents to us is that he has some difficulty in the swallowing. it has to be differentiated from something, a globus-like of a sensation. Globus is something like a foreign body sensation in the throat that disappears on swallowing. So there is a difference when a patient says that there is a foreign body sensation that disappears on swallowing versus a patient who comes to us with a complaint of difficulty in swallowing. So whenever you have a patient with dysphagia, there could be multiple causes. The esophagus is around 22 centimeters long, with the upper part covered by skeletal muscle and the lower part covered by smooth muscle. You could have intraluminal causes like webs, rings, eosinophilic esophagitis, stricture, malignancy, etc. There could be multiple causes which are affecting the musculature of the esophagus, stroke or myotropic lateral sclerosis, which affects the skeletal muscles predominantly, or entities like achalasia, Des or jackhammer, which could affect the smooth muscle part. So how do you differentiate and how do you reach to a diagnosis in such cases? So whenever you talk of clinical approach to dysphagia, it is imperative that first you realize whether this is a patient who has oropharyngeal dysphagia or who has a esophageal dysphagia. So once you pin down to esophageal dysphagia, the next step would be to find out whether this patient has more of a mechanical kind of a dysphagia or something which is affecting his motor system. So he has a motor dysphagia. So as with all clinical conditions, three things matter. It is a good clinical history, examination and investigation. All the more so in patients with dysphagia, an excellent history, as Dr. Mittal had also reiterated, that you need to have very good clinical history in these patients. Examination, of course, plays a role, but not much. And the third part, or the important part, is a set of investigations which would help you in evaluating the cause for dysphagia. So a patient with dysphagia comes to you, the initial questions that could be of help is whether the patient is having any delay in initiating the swallow, whether he has some deglutative postnasal regurgitation, whether he has deglutative coughing, or whether patient has repetitive swallowing, which he needs to achieve satisfactory clearance. So if the answer to any of these questions is yes, there is a 80% chance that the patient is having oropharyngeal dysphagia, and you could direct your investigations accordingly. If the answer to all of this is no, it is more likely that the patient has a esophageal dysphagia, and then you could direct your investigations according to that. If you narrow down to esophageal dysphagia, the next thing that has to be seen, the next thing that you ask is whether the patient has predominant dysphagia to solids or whether he has a dysphagia to both solids as well as liquids. In case of a predominant dysphagia to solids, it is very likely that it is a mechanical cause, whereas a patient presenting with dysphagia to both solids and liquids, a motor cause is more likely. Once you have a mechanical cause, the next question is whether the dysphagia has been progressive, in which case entities like stricture, esophagitis, or cancer are more common. If the patient is complaining of an intermittent kind of a dysphagia, entities like an esophageal web, rings, or eosinophilic esophagitis are common. If the patient is saying of a motor cause, then again, the similar question, whether he has a progressive dysphagia, in which case achalasia or absent contractility or scleroderma could be thought of. If the patient is complaining of a motor kind of a dysphagia which has intermittent symptoms, this is more likely. So there are a few basic things which have to be seen in a clinical examination, though not much could be seen. But yes, you should not miss on these points like having a supraclavicular lymphadenopathy, some allergic shiners or sclerodactyly or other signs of Raynaud's phenomenon. Having an oral examination to see for palatal movements or tongue movements could also be of help in helping us to see what has been the cause of dysphagia. In these patients, if you have any of these, you could narrow down your investigations accordingly. A patient, now coming on to investigations, a patient who you think has oropharyngeal dysphagia, two important investigations. One is a video fluoroscopy. Doing a video fluoroscopy requires a special setup where you have this chair and the lateral X-rays can be taken. So it is a real-time evaluation of a swallow, which is done under fluoroscopic evaluation. The other method to see for other investigation to see for oropharyngeal dysphagia is by doing a video endoscopy. This is through a nasal laryngoscope, or you can also use a neonatal endoscope intubated through the nose and see the movements of the various structures during the phase of swallowing. So these are the two investigations. However, we are focusing more as gastroenterologists on esophageal dysphagia. So that would be the major talking point in my discussion subsequently. So for a patient who presents to you with esophageal dysphagia, three important investigations which are done is, one is an upper GI endoscopy, which would help you with more diagnosis of mostly of mechanical causes, an esophageal manometry, which helps you in diagnosis of motor causes of dysphagia, and barium swallow, which gives you additional information, and especially it is useful in finding out the reasons for proximal obstruction, and sometimes for seeing for any reasons for extrinsic compression. It adds on to the value of these investigations, as Dr. Mittal had discussed, that we need to have complementary tests before we reach on to a conclusive diagnosis. The most common, the common entities that you encounter while doing an upper GI endoscopy would be something like growth or malignancy, some webs or rings, stricture causing mechanical dysphagia. One entity which has to be seen very carefully is eosinophilic esophagitis. So if you see a feline-like of esophagus having multiple stacked circular rings or multiple strictures, mostly the strictures in eosinophilic esophagitis are proximal. Whitish exudates, which represent eosinophilic microabscesses or linear furrows, these are quite specific for eosinophilic esophagitis. It is important to know that 15% of the patients, which is a significant number, who are evaluated for dysphagia tend to have eosinophilic esophagitis. But it is also important to know that up to 25% of patients with eosinophilic esophagitis have an absolutely normal endoscopy. So it is imperative that you take biopsies for all patients presenting with dysphagia during an endoscopy. And if you can see that there are more than 15 eosinophils per hypoar field, this is in favor of eosinophilic esophagitis being a cause of dysphagia in such patients. One more important entity is that GERD. So in a patient with GERD, you need not always have a stricture. It is known that GERD by itself is known to cause dysphagia. There was a paper published quite long back in 1993, which said that esophagitis itself is as important as esophageal stricture diameter in determining the symptom of dysphagia in these patients. It is because the reflux itself induces an inflammatory response. The chronic reflux can also lead to alterations in the esophageal sensitivity. This is because of the prostaglandin release. And you also tend to see a lot of patients having ineffective esophageal motility as a spectrum of GERD. So all these things lead to a sense of dysphagia in these patients in the absence of strictures. So GERD is an important cause for dysphagia. Now, how useful is upper GI endoscopy for motor disorders? In most cases, you can make a diagnosis that this patient is likely to have achalasia cardia, but you need to have a high index of suspicion. Unless you see it very keenly, you are likely to miss. So like in this case, you can see a fairly open esophagogastric junction, but when you see there are tertiary contractions and there is some amount of resistance to passage of the scope as you go across. You also see some pooling of the saliva, slightly dilated esophagus. So it is in such kind of cases where you have to have a high index of suspicion so that you can order further tests and establish the diagnosis. So it is very important to have this index of suspicion when you're doing an endoscopy. One more important point is, once you have done an endoscopy and you plan an esophageal manometry in such cases, there could be two possibilities that might happen. So once you do an endoscopy and you cross the esophagogastric junction, there it is usually seen that you tend to reduce the lower esophageal sphincter pressures, LES pressures, and also the sedation which is used. Most commonly, most of the centers would be using midazolam, which has a T-half of around 1.5 to 2.5 hours, or you also use opioids like fentanyl, which has a 20-minute short half-life. These tend to affect the esophageal motility. So doing a manometry immediately after endoscopy might sometimes not give you the accurate results. So it would be wiser to pose these patients for manometry after a gap of around 2 hours after doing an endoscopy, so that you have more accurate results. I would not go into the depth of esophageal manometry, as Professor Mittal had already discussed this in detail. So basically what we are seeing in manometry is something of a three-dimensional motility pattern of the esophagus, which is represented in the form of various colors. So what matters in a patient with dysphagia is whether this patient has major motor disorders, which was according to the previous Chicago version 3 guidelines. So which are the major motor disorders? You look for whether this patient has achalasia cardia, which could be of three types. Type 1, where you have a high IRP, but there is no contraction in all the swallows. You have a type 2 achalasia, where you have a high IRP and a pan-esophageal pressurization. You have a type 3 achalasia, where you have a high IRP and a low distal latency. The other major disorders include hypercontractile esophagus, where this patient has a very high distal contractile integral, also called as a jackhammer esophagus. You look for distal esophageal spasm, where these patients have a very low distal latency, or you look for ineffective esophageal motility, where the DCI is less than 100 in all the swallows. So these are the major motor disorders which clinch the diagnosis, and you can attribute them as the reason for dysphagia in these patients. But there would also be some patients who have some minor disorders of motility, like peristaltic breaks. It is not known that what is the significance of these minor motility disorders, and it is thought that these directly do not lead to dysphagia. So in all such patients, they require to be evaluated further to see what is the reason for dysphagia. For example, GERD could be one of the reasons for dysphagia in these patients, and it is not directly these peristaltic breaks which are causing the symptom of dysphagia. One important entity is an EGG outflow obstruction, and of late, with the evolution of high resolution manometry and the greater understanding of manometry, this entity is now gaining lot of prominence. Possible causes for EGG outflow obstruction include some tumors, which could be both intrinsic or they could be extrinsic compression. Even small hiatus hernia are known to cause EGG obstruction, which looks paradoxical otherwise. Artifacts of the manometry machine, vascular compressions, incompletely expressed achalasia. It is thought that some of these patients might eventually lead on to achalasia, and that has been shown in multiple papers. So EGG outflow obstruction is now gaining prominence. What is very important is, in such cases, doing a very good endoscopy and having a very good retroflexed view, where you could clearly see the esophagogastric outflow obstruction. Now, in the Chicago version 4, as Professor Mittal had discussed just now, a special emphasis has been given to EGJ outflow obstruction. It is said that for diagnosis of EGJO, the patient needs to be symptomatic. His IRP has to be elevated in both supine as well as sitting positions, with at least 20% of the swallows showing compartmentalized pressurization. You also need to have additional supportive tests, maneuvers like a multiple rapid swallows or rapid drinking challenge, or a barium swallow or an endoflip, before you label this patient as a EGG outflow obstruction. So this is one entity which you need to evaluate more further. Also, we have to be very careful for an entity called a pseudoachalasia. Very recently, we encountered a patient who had a very typical graph showing type 2 achalasia. Incidentally, his endoscopy done around 3 months back outside was reported as normal. But when we did the endoscopy, we could see that there was infiltration at the esophagogastric junction and biopsy-proven adenocarcinoma. This was very strange, because this would eventually, we would have thought that this would present more like an EGG outflow obstruction or maybe compartmentalized pressurization, but finding a pan-esophageal pressurization classical of achalasia was very difficult to interpret. So going through the literature, Dr. Carlson had said that features which favor pseudoachalasia more than achalasia, especially malignant pseudoachalasia, are, of course, as we know, advanced stage, short symptom duration, weight loss of more than 10 kgs, but none of these are very specific to rule out true achalasia. One most important thing would be if you encounter a significant resistance to pass the esophagogastric junction during upper GI endoscopy, which would be more than a mild resistance, which is usually encountered during achalasia. You should be suspicious for ruling out any malignancy or the appearance of any nodularity, ulcers, or bleeding. In such cases, it would be wise to repeat an upper GI endoscopy, go for an EUS if required, or a CT scan to rule out pseudoachalasia. The next test, which is usually useful, is a barium swallow. The conditions where it would be useful is that in suspected motor disorders where you don't have a clear-cut diagnosis, like in this case with an achalasia cardia, which gives you a classical parrot beak appearance, or this case with a spastic motility disorder where you have a corkscrew esophagus. It is also very useful where there is high obstruction, which could not be clearly delineated on the endoscopy. You have an upper esophageal stricture over here. In terms of therapy of dysphagia, barium swallow is very useful in delineating the length of the stricture so that you can further determine the adequate therapy, appropriate therapy for such patients. There are some modifications to the barium swallow, which are used in most of the studies, especially in patients with dysphagia, one of which is a timed barium swallow. What is done in a timed barium swallow is that diluted barium is given, around 150 to 250 ml of barium is given as per tolerability, and either the column of the remnant barium at 1 minute, 2 minutes, or 5 minutes, or this area is evaluated. A recent publication in 2018 found out that the remaining column of 2 centimeters at 5 minutes had a sensitivity of 85% and 86% specificity for diagnosis of achalasia cardia. So timed barium swallow might be more useful than a regular barium swallow. Also, to assess the treatment efficacy of achalasia, it is seen that you should have at least a 50% reduction in the height of the barium column at 5 minutes. So that would be a valid indicator to say that your therapy has been appropriate. Another important thing that many people use is a barium tablet. So it is a 13 millimeter barium tablet which is swallowed, and the presence of the barium tablet at 5 minutes improves the sensitivity from 85% to 100%. So if you have a retained barium tablet at 5 minutes, it is a very sensitive indicator for achalasia cardia. The recent modality which has been introduced is called as the endoflip. So endoflip, what it basically does, it gives you an distensibility index, as Professor Mittal had discussed. It gives you a distensibility index. It gives you a measure of the opening of the esophagus, and the present applications for an endoflip for in patients with dysphagia is usually assessing the real-time adequacy of either a POEM or a Heller's myotomy in patients with achalasia. And it is also used very frequently in patients with eosinophilic esophagitis. But it is likely that this could gather a lot of application in the coming future. So just to summarize, a take-home message for any patient presenting with dysphagia, the history is very important, based on which you could narrow down to whether this patient has an oropharyngeal dysphagia or an esophageal dysphagia. If he has esophageal dysphagia, whether this patient has predominantly motor-related dysphagia or a mechanical dysphagia. If you could narrow down to oropharyngeal dysphagia, a video fluoroscopy or a video endoscopy is useful. For patients who are having motor esophageal dysphagia, starting with an endoscopy with biopsy, followed by an esophageal manometry, and then as per requirement, a barium swallow would be the right way to proceed. For patients who have suspected mechanical dysphagia, an endoscopy with biopsy, barium swallow, esophageal manometry if required might be useful. In some patients, you might have to additionally do a US or a CT scan. If none of these yield, you could either give a empirical therapy with PPIs for GRD, or you could go in for a 24-hour PH study as quoted in some studies. If none of these are useful, then these patients usually tend to have functional dysphagia, which might have other pathologies as just discussed. So thank you very much.
Thank you, Shri Hari, for a very nice presentation. And I think we have already exceeded a lot of time, but we have time for a few questions. And Rajesh, if you can start the ball rolling.
Okay. So we have a question from Dr. Jayanti, who wants to know whether EGJO obstruction is a spectrum that progresses to achalasia.
Not that we know.
I think Dr.
We have,
yeah. See, if you look at the anatomy of LES and the lower esophageal sphincter, we clearly note that lower esophageal sphincter is tonically contracted because of the persistent excitation by the excitatory neurons. So what happens in patient with EGG obstruction is the basic premise is that the inhibitory neurons are gone. Whenever the distal esophagus continue to be normal in terms of the balance between excitatory neurons and the inhibitory neurons, so you will have a normal peristaltic studies. So I believe that EJJ, in the absence of any organic obstruction like malignancy or paramegaloblastic syndrome or things like Chagas disease, it may just be harbinger of incoming progression of the pathologies of the distal esophagus, which can then subsequently go on to develop type 3 and type 2 achalasia.
Thank you, Dr. Arora.
So can I say something here?
Sure, sir.
So that is the general perception that these disorders can progress from mild to severe. But in reality, very, very rare. We have, people have done long-term studies, and I have long-term, I've been doing almost 40 years, and very rarely do you see progression of these disorders. Achalasia, for example, first time you see patients with dysphagia who have achalasia, that is their first presentation is achalasia. We rarely see progression of nutcracker, spasm, and outflow obstruction is relatively recently described. So, we don't have the long-term follow-ups in these. I think based on 40 years of this doing manometries, I think it's very rare to see these disorders progress. Now, why is that the case? Nobody knows.
Professor Mittal, there's a question for you by Dr. Salunke. He says that in India, we are most commonly using water perfusion manometry. So how would we do the upright swallows? Would there be a hydrostatic assessment?
Yeah, so you will have to adjust your pressures. There is going to be some change in your baseline pressures when you go from 2.2, but I think you can adjust it. You can do, when you sit somebody from the supine to upright, you can figure out how much change in the hydrostatic pressures and either subtract it or take into account in your analysis. I think that's doable.
So Rajesh, can I answer that? I think
sure.
the water perfusion system, somewhere in the analysis, there is a point which says adjust for hydrostatic changes. So you can change that. Most systems have that. So when you make the patient sit up, and especially when you're doing a multiple rapid swallow or a rapid drink challenge, you cannot do it in the lying down position because you don't want the patient to, aspirate. So that is the time. There is a button there which says that you can adjust for the hydrostatic changes.
Okay. There's another question that anyone can take it. Sorry, this is to you, Dr. Bhatia, by Dr. Jayanti's asked, should all motility centers have an impedance system?
So the answer is yes and no. So for people who have the older system and have the water perfuse system and are continuing to do the diagnostics using the Chicago classification, you really don't need to invest in the impedance. But for people who want to go get into research or want to study pathophysiology of symptoms, impedance is quite useful to find out whether the bolus is being transported properly or not. And if by any chance the Chicago system decides to get impedance into the analysis of the peristalsis, in that case, then we will all have to move on to impedance. But I think going by the difference between Chicago 3 and 4, that was a good 7 or 8 years that went in, Dr. Mittal, between 3 and 4.
Yeah.
2012 to 2020. So we can wait till then, wait for more data to come. But for a day-to-day analysis of work, like a patient comes in with dysphagia, you want to know whether he has achalasia or not. I think the just measuring pressures is absolutely fine.
So one of the things I said is the current I described is the current where we stand is the Chicago. But if you just want to move maybe 2 years ahead, futuristic, I showed you the value of the impedance in measuring the cross-sectional area and the distension phase of the peristalsis. So I like to see it's right around the corners. I like to see all my Indian colleagues support me and start doing some impedance and distension contraction plots. We have a software, actually we very simple software. Those distension plots that I showed you, it can generate beautifully these distension contraction plots, and a lot of patients, 50% of the patients that achieve motility, that's normal. Patient has dysphagia, and you say, go home, you have psychogenic or you have hypersensitive esophagus. That's I think is immoral when we telling, if my mother, somebody told me has dysphagia and some doctor tells her this is psychogenic, I would get so mad because inability of our techniques to measure the real thing. So I think that's where, I think it's just a little futuristic and it's right around the corner.
Can I ask a question to Dr. Mittal, sir?
Yeah.
You think this, looking at the distensibility in a patient with a normal contractility, normal barium and normal esophagus will have some therapeutic implications? In terms of
that is the ultimate question, is one of the things is just diagnosing. Okay, so there is some money in making the correct diagnosis, not calling people psychogenic or hypersensitive. So I think that's one thing, very important. Then the next thing is, what is the therapy for these disorders? And I think that, is the next stage that we are working on, but I think I don't know the answer. One of the things that we always do is do empiric dilation using Savory 20 millimeter. I always do, and it does help a lot of people with functional dysphagia. Now, whether does it improve the distensibility when you're doing, say empiric Savory dilation, I don't know. Whether there are some medications like smooth muscle relaxants and other things that can improve the distensibility. And then what exactly is the reason for the distensibility, impaired distensibility? That is another question. That's the topic of my next NIH grant that I just submitted a few months ago. So there's a lot of work that needs to be done, but it has to start at least making the correct diagnosis.
Do you think it may have more to do with the Meissner's plexus distensibility than the mind prick? Because
the distensibility is more complex. So distensibility means 3-4 things that measure that determine the distensibility. One is the actual relaxation that is mediated through nitric oxide nerves. That is only one component. Second component I showed you is the hypertrophy of the esophageal musculature that causes reduced compliance. So that's called the passive property of the esophageal wall. And now, third thing, we have found that in a lot of people, the problem is there is something else that is causing reduced distensibility. And it will take me some time to explain that how the esophagus is anchored to the diaphragm. See, normally when you swallow, esophagus shortens. And the shortening of the esophagus is very important in the distension and relaxation. And what we are finding that in these people, it doesn't shorten. And if it doesn't shorten, it actually causes narrowing of the esophagus. So there are multiple reasons for reduced distensibility. The other thing I want to just point out is if you really look, you don't have to do very sophisticated impedance things that I told you. If you carefully, your radiologist looks at the barium swallow, unfortunately, the radiologists don't pay attention to it. They can look for the distance, whether the esophagus is distending well or not during peristalsis. And a lot of times I can see that the esophagus, but these radiologists, they are not paying attention to it.
The last question, I think we have overshot our time. Munish, should I ask?
Yeah, what is the difference in management of different types of distal esophageal spasm?
I'm sorry, the question is, what is the question?
What is the difference in management of different types of distal esophageal spasm?
So from my point of view, so usually the distal esophageal spasm patients don't have as much dysphagia as patients with achalasia. Most of the time their symptoms are mild dysphagia and intermittent chest pain. Okay, so a lot of times if the symptoms are, once a month or once in 3 months or once a year, I tell them to do PRN nitroglycerin or, PRN anticholinergics. Now, if the symptoms are more severe, then I try on the calcium channel blockers, daily long acting. Now, if really the symptoms are daily and you see on the CT scan or ultrasound imaging very thick walled esophagus, then I think you have to think about a long myotomy. But those are very rare cases. Those are very rare cases. So I don't like to send patients to surgery, but POEM, I think in India, a lot of POEM is being done, and that's a good strategy for patients with dysphagia, but they have to show that they have severe dysphagia. And, before I will send them to surgery.
Thank you. Thank you, everyone. Is Dr. Ashish going to take over?
Yeah, thank you. Now I would request Dr. Srihari to announce that we are starting a course on esophageal manometry. Dr. Srihari.
Yeah. Dr. Anil, would you like to introduce it?
Yeah, I think this is, we have very few people like Dr. Deepak, Dr. Rajesh Senani, Dr. Shobna, and Dr. Monish, who have been doing excellent work in this big country on esophageal motility disorders. So the basic purpose of having this webinar was we should clarify the basic concepts of reading, interpreting, and using it in day-to-day clinical gastroenterology, the basic concepts of HRM. With that in mind, we have planned to start a 2-week certificate course in esophageal and anorectal manometry, which will be conducted as a certificate course in Department of Gastroenterology. We will invite the guest speakers on the Zoom meeting for teaching the various fellows who are going to join to us. The logistics of the course are going to be presented by Dr. Srihari.
So why do we need this course? Why we thought that we needed this course was because as we now see that the field of gastrointestinal motility and functional GI disorders is growing very rapidly. There is unfortunately, as of now, there is no formal course which is available for learning these disorders or learning about GI motility in detail in almost I think any of the centers. The centers which are offering manometry services are increasing. However, their adequate exposure and training to manometry evaluation and assessment is still lacking. And we think this course would be the first of its kind which would offer an integrated curriculum, including all theoretical and practical aspects of manometry in a comprehensive and a systematic format. So what this course basically offers is that it would be a very well-structured course which would cover the basic sciences, clinical application and approach, and would also give the candidates hands-on experience in esophageal manometry, anorectal manometry, and also with biofeedback. We would also encourage for them to have exposure to other motility studies like pH impedance studies, breath tests, etc. The salient features of this course would be there would be live demonstrations. We would encourage hands-on training, lectures by local faculty as well as invited lectures by other national and international faculty of repute. There would be daily didactic discussions with the faculty. This would be just to give an example of a basic course schedule. The course would be 2 weeks full-time, conducted at the motility lab in Gangaram Hospital. We don't intend to charge the students for this course. Accommodation, we would make all attempts to provide accommodation also to these candidates. So we welcome anybody and everybody who's interested in this course to join according to their availability.
And Dr. Arora, would you like to make a comment?
Yeah. I think with that, we'll come to the end of the session. We certainly seek the blessings of the stalwarts of motility in India. We are blessed to have excellent international and national faculty who have deliberated very well on the basic concepts of reading, interpreting, and clinically utilizing the HRM in diagnosis of common esophageal disorders, which are in fact so common and important that we are learning that we know not much about it, but certainly with advances in the technique of reading and interpreting and the newer classification coming into being, we will certainly be wiser. We'll certainly seek the blessings of the of the chairpersons, moderators, and the national and international faculty for carrying this course forward. So I'm thankful to all the participants, including the audience, for having spent their important Saturday evening to be with us on this important topic of esophageal motility disorders. I'm thankful to Microlabs, who are our academic partners, for having sponsored this session. Thank you so much.
Can I say one thing?
Yes,
so
sir.
I also want to just advertise for I have once a month research, lectures from all over the world, the top-notch people who running their, research labs. They come out and give a lecture, whatever is going on in their lab once a month on Mondays usually, but we can announce it. If there are people interested in there, I can send you the link. And the beautiful thing about it's called the ZEM group, ZEM, Zooming Esophageal Motility Masters. So it's a ZEM group on Zoom that you guys can join and learn whatever is actively going on in the world, not only in the US or wherever is going on.
We would welcome any comment from Dr. Monish, Rajesh, Shobna, Deepak.
That's excellent, sir. I think we'll email you our ID and we would like to attend such meetings.
But there are more participants. I just see 9 or 10 people in the participants.
This is not the attendees, sir. This is only the faculty. The attendees are on a separate parallel group.
And how many attendees for this meeting today?
I'm not sure.
We'll let you know, sir. This is just a panelist link. Otherwise, it's very difficult.
Attendees are, I think, more than 150 to 200, which I've been told.
Very good. That's very good for a motility meeting. Yes.
Yeah.
Wow.
And this, the entire video will be available on YouTube. So anytime it can be used for the students and the gastroenterologists who want to learn manometry and
we look forward to the constant blessings from our Indian stalwarts, Dr. Deepak, Monish.
Dr. Shobna, you had something to say?
No, I just wanted to tell Dr. Mittal that
certainly with persistent feedback from Dr. Ravinder, who is going to be a part of.
We lost you. I didn't hear.
Lost you,
Yeah, ma'am, we couldn't hear you. Can you repeat?
No, we lost you in the your last two sentences could not be.
So what I said was that we constantly keep looking for the blessing from our Indian stalwarts. Presently, we have Dr. Deepak, Monish, Rajesh, and Dr. Shobna. In this new venture, since we are new to the subject, certainly we'll like to have your expertise as our national faculty for giving these didactic lectures to our students and the fellows. That will certainly encourage in spreading far and wide the basic knowledge of esophageal motility, which is so important. And certainly we'll consider Dr. Ravinder Mittal not as a US guy, but as a very much Indian of our own. And as even Biden has, I think, inducted more than 100 people from India in his own cabinet. So we'd certainly love you to be a part of our own meeting on regular basis.
Yeah, no, if I can help. Yeah, no, I'll love to help if I can.
Yes.
Thank you.
Thank you.
Thank you, everybody. Good night.
Thank you for organizing this beautiful meeting. Yes.
Thank you. Bye-bye.
Thank you.
Thank you.